Students, so today we will be discussing about various headache syndromes and the clinical features. So I will be mainly dealing with some clinical features which will help you to diagnose the presenting complaint or presenting headache is which type of headache. Some points actually. So as an introduction, I would like to say that the headache is actually a very big headache for the patient as well as the treating doctor. I am saying it because whenever a patient comes with a new onset headache, so it's actually a dangerous sign. New onset headache is actually a dangerous sign and you have to investigate thoroughly, otherwise you may miss many dreadful diseases. Especially you may have to go to imaging like CT or MRI like that, or you have to closely watch the clinical symptoms. But a chronic headache, a long-standing headache patient comes to you and he will say a lot of symptoms, and these symptoms actually may not fit into a headache syndrome. This headache list, you have what a various list of headaches, and his clinical scenario may not fit into a headache syndrome. So it provides actually is a big headache for you, but you will try some medicine permutations and combination, and sometimes the patient may get a relief, and by experience also you can say which type of headache is this. Okay, so I will be dealing with primary headache syndrome mainly today and some clinical features to differentiate various types of headache. So with that we will start the topic. The cardinal words I will say primary and secondary headache. Okay, so most common type of headache is primary and it is usually chronic. Okay, and secondary type I will say it is more dangerous. So primary headache, what are the primary headache syndromes? It's a short note actually. The primary headache syndromes are migraine with or without aura. Okay, migraine with or without aura. Migraine is actually a syndrome. It's actually a neurological type of headache with lot of clinical features that we will deal later. Aura is actually pre-runner, a premonition symptom of headache, because maybe some flashes, bright flashes of light, zigzag lines may appear in the visual field, which actually will help the patient to be alert. So he can sense that the headache is coming. Now the migraine is going to appear. Classically, you know, aura is seen with epilepsy. This epileptic patient will have some pre-symptoms which will actually help them to go and stay calm, so that during this epileptic attack he may not have some injuries. So aura is classically seen with epilepsy, but in classical migraine you will have aura. But the commonest type of migraine is migraine without aura. Okay, classical migraine you will see aura, but common type is migraine without aura. Okay. Second is tension headache, then trigeminal autonomic cephalgias, including cluster headaches, primary stabbing, cough-related, exertional, sex-related headaches, and daily persistent headache syndrome. Okay, you have to by heart these names at least. Secondary headache, the types are medication overuse headache, intracerebral bleed, IC bleed, SDH and SH are subdural hemorrhage and subarachnoid hemorrhage. A new onset thunderclap headache, a new onset worst headache of the day, thunderclap headache, something is breaking in my head like that, should always lead you to suspect subarachnoid hemorrhage. Okay, and patient in clinical examination you will have some neck stiffness also. Okay, neck stiffness. Increased ICT, raised ICT, intracranial tension is raised, seen in brain tumors, idiopathic intracranial hypertension. Infection, meningitis, encephalitis, inflammatory, giant cell arteritis, vasculitis, and referred pain for neck, surrounding areas, etc. Red flag symptoms in headache. What are the red flag symptoms? So, some symptoms which actually will tickle your alarm, that you have to be cautious. You have to be cautious in dealing with patient, otherwise you will miss a serious condition. That is known as red flag signs. One is sudden onset. I told you, new onset, sudden onset headache, the worst headache of the day will actually pour. Maximum headache at the onset, subarachnoid hemorrhage, cortical venous thrombosis, and pituitary apoplexy. Focal neurological symptoms, if it is present, it is suggestive of intracranial space occupying lesion, ICSOD. It can be vascular, it can be neoplastic, or it can be infection. Infection means brain abscess or something like that, right? ICSOD. Neoplasm means meningioma, glioma, anything. Okay. Constitutional symptoms. If there is weight loss. If there is weight loss, what are the two things you have to rule out? One is infection, of course, chronic infection, tuberculosis, etc., HIV, and neoplastic, lymphomas, gliomas, etc. Okay. Pyrexia, fever, you will have an infection, vasculitis, again lymphomas, meningism, seen in meningitis and meningoencephalitis, rash, meningococcemia, meningoencephalitis, raised ICT, worse on head movement, suggestive of intracranial space occupying lesion, vomiting, again is a feature of raised ICT. A new onset headache more than 60 is suggestive of temporal arteritis. But temporal arteritis actually will be dealt detailed in vasculitic class. So I will say some points, because when I say age more than 60, new onset headache, temporal arteritis, you will get a little confused. So temporal arteritis is actually otherwise known as giant cell arteritis. You will have severe unilateral or sometimes bilateral unilateral type of headache in the temporal artery distribution. Okay, so patient will be more than 50, or I will say more than 50 or 60. Fever will be there sometimes. Patient will complain of body ache, fever, etc., long standing fever and severe headache not responding to treatment. So whenever you palpate the temporal artery, it will be tender and sometimes pulse will be absent. Temporal artery pulsations will be absent. So that clinches the diagnosis. Okay. Now if you don't thoroughly examine, or if you don't suspect temporal arteritis, you will terribly miss it and you have to give steroids. Otherwise, it will not subside. It will not subside. Okay. Now we will go into the primary headache syndromes. Primary headache syndromes. First, I will be telling about tension type of headache. This is the most common type of primary headache syndrome. You almost 1% per day you will see in the OPD, right? Most common type, episodic or persistent. You can see the diagram. It is actually like a band tied into the head. A band is actually tied tightly into that. Patient will tell like that. Symptoms will be like that. Okay. Pathophysiology actually is not clear. It's associated with anxiety, depression, may have constitutional symptoms like body, sometimes feverish feeling, etc. They can tell clinical features of tension type of headache. It is experienced as a dull, tight or pressure feeling. Something is compressing on my head like that, as something is tied tightly into my head like that, patient will say. Felt as a band tied around the head. Radiation of pain may occur. And in contrast to migraine, pain can remain unabated for long duration. That is actually the difference. Okay, migraine lasts for maximum 4 to 72 hours like that, but it can remain abated for a longer duration. Okay. Pain is less severe when the patient is occupied. That is very important. When he is involved in other activities, he may even forget the pain. Okay, that is very important, because migraine and other types of headache, there is no relation like that. When he is occupied, when the mind is little free, actually the headache will little decrease. Tender points in the skull. It is if you touch the skull also, you will tell there is pain like that. Okay. Analgesic abuse may be there. But the patient may be taking lot of painkillers to abolish the pain. So analgesic abuse may be there. Treatment is actually, it's an exclusion diagnosis actually. Okay, I will say it's an exclusion, because you have to rule out other types of treatable types of headache or dangerous headache. Then reassure the patient. Okay, reassure that it's not a very problematic thing. It is actually a mild type of headache. It is like this. You can get relieved by taking some balms or something like that, or stress relieving like that. You can advise them. Physiotherapy with muscle relaxation and stress management. You can ask the patient to take deep breathing exercises and all. So, and stress management. Stress management means ask him to involved in some activities which relieves his stress. Maybe music, maybe gardening, cooking, etc. Such that he can get involved in any type of activities which will relieve his stress. That is a part of physiotherapy. Discourage excess use of analgesic. We warn him that it is actually a mild type of headache. If you use excess analgesics, you may end up in other problems, like you can have acute renal kidney problems, etc., etc. So you have to warn him, don't take analgesic. If at all he needs, not relieved with all these things, try a paracetamol, just acetaminophen or paracetamol tablets. Okay. And sometimes if it is chronic, persistent, causing much discomfort to the patient, you can give low dose amitriptyline. Amitriptyline is actually a tricyclic antidepressant. Very low dose, 5 mg or 10 mg of amitriptyline will work in this patient. Fine. Now, migraine. Migraine is actually, but almost all the patients coming to you with headache will tell that I have got migraine. But migraine is not like that. Migraine is having some typical symptoms. If it fits into this symptomatology only, you can diagnose migraine. Fine. You can see a picture I have noted. This is actually the aura of migraine. It's not typical, but patient can have zigzag lines, bright flashes of light and zigzag lines in the visual field. So that is an aura of classical migraine. So it usually appears before middle age. Female is to male ratio is 4:1. So female preponderance is classical. One is classical of migraine. Female preponderance 4:1. Pathophysiology. Lot of mechanisms are there. So I will try to simplify it. Aura. I already told you it is seen in classical migraine 20% of the patients. Right. It is due to a dysfunction of the ion channel. First excitation, then hyperpolarization. First excitation, then hyperpolarization. Okay. Then second, you can have a headache phase. Aura, after that headache phase. Headache phase, you have vasodilatation of the extracranial vessel. That is why some patient will say, I have a pulsating feeling in the head. Tum, 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 like that. Some knock sounds will be there in the cranium. So you will say like that, a pulsating type of it. So a pulsating type of headache, patient says you have to think maybe it may be migraine. Okay. And the other pathological mechanism is activation of the trigeminal vascular system. Familial trend. There is actually a genetic predisposition. Father and mother were having migraine. Sometimes kids may also have symptoms of migraine. So family history, asking family history can add a little benefit to a diagnosis. Okay. Hormonal changes can actually precipitate migraine. Okay. There are many precipitants for migraine. The notorious one is OC pills, oral contraceptive pills. So a adolescent female or a young female coming to you with migraine, you have to ask for recent drug intake, because they may be taking drugs for prolonging the periods or maybe regularizing periods, some more hormonal tablet. That you have to ask, and that tab might be the culprit for precipitating migraine, because sometimes this patient will have a long course of inactive phase of migraine, because they may not have symptoms for many weeks or months, and suddenly she came with an acute attack of migraine. You have to think of precipitants. OC pills, cheese, chocolate, red wine. Red wine produces worst type of headache. Red wine and migraine has got it worstly precipitate migraine. Some smell, peculiar smell, may be associated with perfume, turpentine, paint, etc. Skipping meals, that is a precipitating factor. If the lunch is skipped or prolonged, it may precipitate migraine. Sunlight, and I will ask also at travel. Okay, long travels can also precipitate migraine. What are the clinical features of migraine? So you see this diagram, it is actually usually unilateral. Migraine is usually unilateral. Suppose the patient is saying pain here always is simultaneous, the chances of it being a migraine is less. Okay. Tension headache, people usually say bilateral type of simultaneous type of pain. Migraine is usually unilateral. Migraine without aura is common migraine. With aura is classical migraine. 20% have aura, usually visual or sometimes sensory. Severe throbbing type of headache. Phonophobia, vomiting. I think it is 2 times it has photophobia. It is phonophobia. Okay, it is phonophobia. Photophobia is actually irritation on seeing bright light. Phonophobia is irritation to sound and vomiting. So patient will actually prefers to stay in a dark closed room without any sound. If you have got a family member who is having migraine, you will have experience. They will be lying quietly in a dark room. If you go and call them or if you put light, suddenly they will get irritated. Remember that. So photophobia, irritation to light, phonophobia, irritation to sound, and vomiting. And sometimes this vomiting can decrease the intensity of pain in migraine. Okay, that's also a classical symptom of migraine. It lasts for 4 to 72 hours, aggravated with movement. Head movements can aggravate migraneous pain. And I already told you, prefers to stay in a dark room. Management, you have to, you should know, you have to avoid triggers. You have to advise the patient to avoid triggers. Suppose the patient is having problem with perfumes, actually ask them to stay away from perfume, don't use the perfume. There is a habit that they have got problem with perfume, still they use a lot of perfume. So you have to advise them, don't use it. Some particular smell may be the precipitant, chocolate, food additives, whatever it is precipitating the migraine, you have to ask them to avoid that. Okay. Then travel, sunlight, if they are going to directly sunlight, ask them to keep an umbrella. That they can do. Okay. And try to take meals in time. Okay. That all things you can advise. Acute attack and chronic therapy. This treatment is divided into two, that is acute treatment of acute attack as well as prophylaxis or chronic therapy of migraine. Acute attack, these drugs are used. One is sumatriptan. Sumatriptan can be is available in various forms. There are a lot of newer varieties now available. Sumatriptan, rizatriptan, naratriptan, many things are available. Okay, oral, nasal spray, subcutaneous, sublingual, even rizatriptan strips are available. It action in 5 minutes. If you are keeping the strips in the tongue, it orally disintegrate very fast and the pain subside. And it is one of the, I will say that it is one of the therapeutic tests for migraine, because if the sumatriptan is only useful for migraine and some benefit in cluster headache also. So if the pain is getting abolished with these oral strips of sumatriptan or rizatriptan, it is diagnostic of migraine. Okay. No other pain will get relieved with sumatriptan. Okay. So you can also use this as a therapeutic trial. So it is available in various forms: oral, nasal spray, subcutaneous, sublingual, etc. Injection, that is subcutaneous injections. Okay. NSAIDs are non-steroidal anti-inflammatory drugs you can give for acute attack. Ergotamine, ergot alkaloids, that can be used now. Prophylaxis, what are the drugs used for prophylaxis of migraine? I think in which all patients you can do a prophylaxis. So if you are getting weekly 1 or 2 attacks or monthly 4 or 5 attacks, you can, or I think monthly 2 or 3 attacks is more than enough. Because that attacks actually, the full day of the patient is lost, and forcing them to take leave from the office, forcing them to take leave from the college, masterly inactivity, they cannot do any work on that day. Suppose that 2 or 3 days in a month is lost like that, you have to consider that patients with prophylaxis, because they cannot stand an acute attack of migraine. So you have to educate them and tell them to take prophylaxis for migraine. What are the drugs used? Beta blockers, especially non-selective propranolol. Propranolol is very an excellent drug. Calcium channel blocker, flunarizine, anti-epileptic drugs, sodium valproate and topiramate. Antidepressant, amitriptyline. Okay. These are the drugs. The management of migraine can be separately as a short note. Cluster headache, the third type of headache, or it is otherwise known as migraneous neuralgia. Here, male preponderance is in migraine what? Female preponderance 4:1. Here, male is to female is 5:1. So here, male preponderance. Fine. Pathophysiology, cause is correctly not known. It differs from migraine. That you have to remember. Lack of genetic predisposition. 1. Lack of dietary precipitants. 2. And male predominance. These 3 points differs it from migraine. Like lack of genetic predisposition, lack of dietary precipitants, and male predominance. Hypothalamic involvement, that is also seen in migraine. Increased incidence in smokers and alcoholics. Okay, increased incidence in smokers and alcoholics. Clinical features of cluster headache. Okay, so headache, the name itself, the headache occurs in clusters, same time for weeks. Same time, it will actually, the clusters will appear almost the same time for weeks. In every week, the same time, the cluster will come, the headache syndrome will come. Or several attacks in 24 hours. In a 24 hour, in a day, you can have several attacks. So, clusters of attack in one day or same time for weeks. That is classical diagnostic of cluster headache. Okay, you have to take the history, then you will get this typical time presentation for cluster headache. Unilateral periorbital, you can see it is periorbital, whereas migraine you can see 1/2 is involved. Here, periorbital type of pain, mimicking sometimes sinusitis like that. Autonomic features, that is very important, that is not seen with migraine. Lacrimation, nasal congestion and conjunctival injuries. If these features are present in a male with a unilateral headache who is a smoker or an alcoholic, you have to think of cluster headache. Fine. A male unilateral periorbital pain with autonomic symptoms, smoker, alcoholic, that actually should provoke you to think of cluster headache. The pain lasts for 30 to 90 minutes and pain is usually severe pain. During the attack, patient may be agitated because the pain is so severe that patient will be agitated, irritated. After attacks, remission for months to years, a long duration of remission. Even for years, patient will not have headache. Treatment against sumatriptan is helpful. The classical treatment is 100% oxygen. This is a different treatment from other headaches. So you have to remember this point, 100% oxygen inhalation. If it is cluster headache, if you make the patient to inhale 100% oxygen, fine, that headache will get relieved immediately. Other less effective treatments are sodium valproate, verapamil, it's a calcium channel blocker, steroids, and lithium can also be tried for intractable clusters. Fourth one, again, trigeminal neuralgia. Trigeminal neuralgia is unilateral lanciating facial pain. That terminology is important. Lanciating facial pain. Pain is usually in the maxillary and mandibular division. This is ophthalmic, this is maxillary, this is mandibular. So pain is usually seen in the maxillary and mandibular division. Age usually more than 50 years. Pathophysiology. What is the pathophysiology of trigeminal neuralgia? Irritative lesion in the trigeminal nerve root. It may be due to an aberrant artery or a benign lesion. The irritative lesion in the trigeminal nerve root is the basis for pathophysiology. It may be an aberrant artery or a benign lesion. Fine. Sometimes demyelination. The myelin sheath or myelin coating is lost in multiple sclerosing or any other demyelinating lesion. It is also told as one of the cause. Clinical features. The pain is repetitive, severe and brief. It is actually causes very much discomfort to the patient. It is repetitive, severe and brief pain. Triggered by touch, that is very important. Cold, eating. Fine. Triggered by touch, cold and eating. Tic dolorix, that is a term used to describe spasms, muscle spasms which make the patient wince and sit silent. The patient actually will sit silently, quietly without any movement because it can precipitate muscle spasms. Okay. So that is the terminology is tic dolorox. Tic dolorox is actually spasms which make the patient wince and sit silently. Okay. Here I will say one more thing. It is commonly mistaken for dental pain. Patient will tell pain like this. It is commonly not touch because the touch may precipitate. It is commonly mistaken as a dental because some characters are overlapping. One is the site here. You can have dental caries and the pain is here. One is it is aggravated by eating. Dental pain also is aggravated by eating or food in the mouth. So what you can do is, one thing you can do an oral examination and found out there is no dental caries, you have to suspect, and the distribution of the trigeminal pain will be like this. It will be correctly distributed along the nerve. The dental pain is not correct distribution of the nerve. It will be a diffuse type of pain. And it may be seen. It may be seen in rust also. The dental pain may be seen in rust also. Okay. You may have lymph nodes here due to dental caries and okay. So it is a close mimicry of dental caries, trigeminal neuralgia. How will you manage? Carbamazepine. Carbamazepine is an excellent drug, especially you can even use oxcarbamazepine. Surgery. Other treatments you can try is gabapentin, pregabalin. Gabapentin and pregabalin are anti-epileptic drugs. Amitriptyline, tricyclic antidepressant. Or finally, alcohol or phenol injection into the peripheral branch. So these are the treatment modalities available. The questions usually asked are headache syndrome, especially what are the headache syndrome? Primary headache syndrome, secondary headache syndrome. Sometimes red flag signs may be asked. Migraine is a very commonly asked question. Full of migraine or treatment of migraine can be asked. Cluster headache is also commonly asked. Okay. So finally, this is a flow chart. A table I tried to arrange these things. Some points may help you. Migraine, unilateral. Cluster headache, unilateral. Tension headache, bilateral. Fine. Duration, 4 to 72 hours in migraine. Multiple episodes in weeks or in days. One day you will have several clusters in cluster headache. Tension headache is variable. Predisposition, female preponderance in migraine, male preponderance in cluster headache. Male preponderance in cluster headache. Tension headache is again varied. It has got individual variation. Predisposition, that I already told you. And smoking and alcohol has got a relation with cluster headache. Anxiety, depression, psychiatric disorders have got association with tension headache. Clinical features, migraine you can have aura. If the aura is present, is classical of migraine. Throbbing type of headache, photophobia, phonophobia, vomiting. Cluster headache, multiple episodes, clusters, the typical history, autonomic symptoms. Autonomic symptoms. Okay. Tension headache, dull, pressure-like feeling, tight band on the head, radiation of pain may occur. Management of migraine, acute attack, NSAIDs, sumatriptan, even ergots, chronic, beta blockers, anti-epileptics, tricyclic antidepressants also. Cluster headache, sumatriptan, 100% oxygen. Tension headache, reassurance, physiotherapy, and mild dose of anxiolytics. Okay. So that's about headaches. I hope I have provided you some information regarding various types of headaches. So you have to remember the cardinal points which I told you, how to differentiate between various types of headache. Primary headache and secondary headache. Primary headache, tension type, migrainous, cluster headache, trigeminal neuralgia. Tension type would only bilateral, associated with this anxiety, psychiatric problem. Migraine, typical, unilateral. Aura may be seen, photophobia, phonophobia, vomiting, precipitated by many factors. Cluster headache, lot of clusters will appear in weeks or per single day you can have multiple clusters. Male preponderance, autonomic features. Trigeminal, typically in maxillary and mandibular division. Treatment is with carbamazepine, etc. You have to remember these points. And also remember the red flag signs of headache, which will help you to diagnose a dreadful disease like subarachnoid hemorrhage, meningitis, temporal arteritis, ixo, intracranial space occupied lesions, etc. Fine. First MCQ will tell, a woman has bilateral headache that worsen with emotional stress. She has 2 children, both doing badly in school. Diagnosis is just very straightforward question. The emotional stress is there, so it is tension headache. The answer is tension headache. But one point I will say, because the emotional stress can also precipitate migraine. So if some of the features of migraine is described add on, this is a straightforward, only stress and 2 children are doing badly because actually the parent or woman will get anxious, so it is tension headache. But some tension is there, but that can also precipitate migraine. So if migrainous features are also described here, sometimes the answer may be migraine. Here it is tension headache. Fine. A woman complains of headache associated with paresthesias of the right and upper limb and lower limb. The most likely diagnosis. Trigeminal neuralgia. Oh, is it? No. Why paresthesia upper limb? No, it is not there. Glossopharyngeal neuralgia? No. Migraine, can it have? Yeah. One is woman. So we will vote for migraine first. Cluster headache is more commonly for males. Clusters, there is no cluster history described here, no autonomic symptom. Paresthesia, right upper limb, and neuralgic symptoms can occur like this aura type of symptoms. It can be visual or it can be sensory types of aura. So more favoring migraine. The last MCQ. Cluster headache is characterized by all except affecting predominantly females. No, it affects predominantly males. That we have been stressing that point. So that is the odd man out. Affects unilateral headache is right, periorbital. Typical 20 to 50 years of life, that is right. Associated with conjunctival, that is right. So this is the answer. That finishes the MCQ. So that finishes the class on headache syndromes, especially primary type of headache. Thank you.
Docemy.